let's start antiarrhythmic drugs. Can you understand antiarrhythmic drugs without understanding the anatomy, histology and physiology of heart? The answer is no. No. You can't understand antiarrhythmic drugs unless and until you know the anatomy, histology as well as physiology of the heart. So my first half of the session, maybe 35 or 40 minutes, I will teach you the physiology of the heart. Okay, then only you will be able to understand the mechanism of action of various antiarrhythmic drugs which are acting in various phases of the action potential. So it's very important to understand from the scratch. Okay, so here you can see the diagram of the heart. Give me a minute. Here you can see the diagram of the heart. There are 3 layers in the heart. The innermost layer is known as endocardium. The middle layer is known as myocardium. And the outermost layer is known as pericardium. These are the 3 layers in the heart. I guess everyone knows that. Heart contracts because of myocardium. Now I am having a question for you. Listen, my question first. So my question is, what makes the heart beat? Our heart is beating every time, non-stop, 24 into 7 into 365. Every time it is keep on beating till lifelong, right? So what makes the heart beat? What is the answer? Of course, the answer is electric signals. Heart beat due to the electric signal. From where the electric signals are coming so that the heart is beating? Is it from the brain? No, no way. So heart is generating its own electric signal which is causing contraction in the heart. That is the unique feature in the heart. It's a very special organ, of course, in human body, because all other organs are receiving signal from the brain. Then only they can contract, like the skeletal muscle, smooth muscle. They can contract because they receive signal from the brain. But heart generates its own electric signal. So heart generate from, my next question to you, from where these electric signals are generated? Within the heart itself. They are not coming from the brain. So these electric signals which are causing contraction of the heart, which are causing beating in the heart, they are generated in special cell inside the heart itself. And these special cells are known as automatic fibers. These special cells are known as automatic fibers. What do you mean by the term automatic? Have you heard automatic vehicle, automatic car? What do you mean by automatic? Automatic means by itself, without other help, by itself. So that is automatic. Okay, dictionary meaning of automatic. So these fibers are known as automatic fibers because they can generate the electric signal by themselves. They are not dependent on brain. They themselves generate the electric signal. After generating the electric signal, this electric signal which is generated over here is spreading to other parts of the heart which are not able to generate it. But once they will conduct the electric signal, once they will conduct it, they will cause contraction of the heart muscle. And these are known as non-automatic fibers. So the great God, you believe in God? The great God has given 2 types of fibers in human heart. Appreciate the 2 types of fibers. What are the 2 types of fibers given in human heart by great God? The automatic fibers and the non-automatic fibers. Now you tell me, what are automatic fibers? Automatic fibers are the fibers which are able to generate, highlight the word generate the electric signal within themselves. So I'm talking about SA node, AV node, bundle of His, Purkinje fibers. They are able to generate the electric signal. That's why they are automatic. Once they generate the electric signal, they transmit the electric signal to other fibers. The other fibers, they are able to conduct the electric signal, which is generated by the automatic fiber, and after conducting, they cause contraction of the heart. So basically, these are the atrial and ventricular fibers. The atrial and ventricular fibers, they are able to contract the heart on receiving the signal, on conducting the signal. They are not able to generate by themselves. So these are non-automatic fibers. So first you understand there are 2 types of fibers. I will teach you the action potential of both of them. So I will teach you many types of antiarrhythmic drugs today, class 1A, 1B, 1C, 2, 3, 4. So which of them is acting on automatic fibers? Which of them is acting on non-automatic fibers? And in which phase of their action potential? What is their mechanism of action? It's very important to understand from the scratch. Got it? So these are the 2 types of fibers given by the God in human heart. I hope everyone got it. So the same thing is written. You can see the type of fibers. There are 2 types of fibers. Non-automatic fibers, automatic fibers. What are automatic fibers? These are the special cells which are able to generate the electric signal. I'm talking about them. I'm talking about the automatic fibers. These are the special cells, SA node, AV node, which are able to generate the electric signal. Okay. So these are the special fibers. These are the ordinary fibers. They are not able to generate. They cannot generate the signal, but they can conduct them. They can perceive them. You can see I'm talking about the atrial and the ventricular fibers. They are not able to generate, but once the electric signal is generated over here, they conduct the signal. So basically they are conducting the signal, and once they conduct, they contract the heart. That's why these are known as pacemaker fibers. Automatic, the other name of automatic is pacemaker fiber, and the other name of non-automatic is contractile fiber. These are pacemaker, they generate the signal. These are contractile fibers, they do not generate, but on receiving the signal which is generated over here, they cause contraction of the heart. They conduct and contract. So they generate, they conduct and contract. They generate the signal, automatic one. They conduct and contract the muscle. These are known as pacemaker fiber. These are known as contractile fiber. Got it? So see the example here, SA node, AV node, bundle of his and Purkinje fiber. You can see, I will tell you the pathway. SA node, this is SA node, this is AV node. You can see bundle of his and Purkinje fibers. And here we include atrial and ventricular fibers which are causing contraction, mainly ventricular fibers. See the atrial and ventricular fibers, how systole is taking place. So I hope you got the basic, the two type of fibers in the heart. Yes or no? Tell me the pathway over here. Here, tell me the pathway. Tell me how the impulse is generated. So in the automatic fibers, how many automatic fibers are there enumerated? And where the impulse is generated and how it is transmitted. So the impulse is generated in SA node. SA node is the real pacemaker. It is the pacemaker. You can appreciate here is the SA node. This one is the SA node. So after SA node, just a second. So the impulse is generated here in the SA node. After SA node, it is going to the atria. So atrias are contracting. Appreciate. After SA node, the atrias are contracting. After that, it is going to AV node. Here is the AV node. So after AV node, it is going to bundle office. Appreciate bundle office. It is going. After AV node, it is going to bundle office. Appreciate bundle office. And that is going to ventricles. So see the complete pathway. It's very good visible in this video. You can see start SA node, then atria, then AV node, then bundle of his, then ventricles. So this is the pathway. The same you can appreciate it here also. The same you can appreciate it here also. You can see this is SA node, this is AV node, this is bundle of his. So it is starting from SA node. It is contracting the atria. Then it is coming to AV node. Then it is coming to bundle of his. And then it is contracting the ventricles. So this is the pathway. I hope you got the pathway. Now the story starts. The real story starts now. Action potential. What is action potential? Can you see this current which is flowing and contracting the atria and ventricle? This current, this electric signal is known as action potential. It's very important to understand this action potential. If you want to understand the mechanism of action of various antiarrhythmic drugs, unless until you won't be understand if you don't understand the action potential. So what is action potential? Action potential is the electric charge that is traveling through the heart and contracting them. So the electric charge is generating over here. See the arrows. Then it is going to the atria. Then it is going to AV node. Then it is going to bundle of his, and then it is going to ventricle. So it is contracting them one by one, and this is how the cardiac cycle runs. So this electric current is known as action potential, and this action potential is different for automatic and non-automatic fiber. I will teach you the graph of both. It's very important to understand the graph. In the graph only, I will mark the mechanism of action of all drugs. So I will teach you two graphs. One graph for action potential of automatic fiber, and one graph for action potential of non-automatic fiber. So I will be teaching you two graphs. Got it? So we will see the action potential of both of them, the graph of action potential. What will be the difference? Why it will be different? Because here they can generate. I will tell you how they are generating, and here they cannot generate. Simply they are receiving and contracting. So which phase is different? In the action potential, actually where is the difference? So this is the pacemaker and these are the contractile fibers. So I will let you know. Okay, so let's combine these two diagrams and make one diagram for the simplicity, for the understanding, for the sake of simplicity. Now you understood now what is automatic fiber, what is non-automatic fiber. These are the pacemaker, these are the contractile fiber. They can generate the impulse, they cannot generate, they can perceive, conduct the impulse and cause contraction of the heart. So this is SA node, AV node, bundle of his. This is atria and ventricular fibers. Now you got it. Let's compile the two diagram and make it one. So have a look. This is the diagram. This is the one diagram. Can you see this one diagram? Say yes. So you can see this diagram. In this diagram, I have highlighted two cells. Can you see my two squares? I have highlighted two cells. Now please understand it, because I will show you mechanism of action of all drugs here only. So you can see this cell I have highlighted over here. It is automatic. It is one of the SA node. A cell of SA node. So it is one of the cell of automatic fiber. A cell, a square, a cell. And here I have highlighted a cell. It is a cell of the ventricle. It is a cell of ventricle which is causing contraction. So it is a cell of non-automatic. So instead of showing you these two diagrams, I will show you this diagram and I will talk about one of the cell. Am I talking about automatic cell, that is SA node, AV node, or am I talking about atrial or ventricular cell, that is non-automatic fiber? So you can understand this diagram. Now the resting membrane potential. So let me take this cell separately, the green color cell, and let me take this cell separately. So can you see the two cells? This is a cell. I have cut a cell from here. Imagine I have cut a cell from here, and imagine I have cut a cell from here. Here I have cut the cell from the ventricular wall, and here I have cut the cell of SA node or AV node. Okay, so these are the two cells. So what is the resting membrane potential of these cells? What is the resting membrane potential of non-automatic fiber and resting membrane potential of automatic fiber? The resting, it is known as RMP, resting membrane potential. I'm starting from the scratch. I'm assuming you know nothing. I'm assuming that. Maybe you are knowing these basics, so it will be a revision for you. So what is the resting membrane potential? The resting membrane potential for non-automatic fiber is minus 90 millivolt. And the resting membrane potential for automatic fiber is minus 60 millivolt. So first you understand or learn the resting membrane potential. Please learn it. For non-automatic fiber, it's minus 90 millivolt, and for automatic fiber, it's minus 60 millivolt. This is maintained via ions. The main ions are sodium, potassium, calcium, and sometimes chloride ions. So with the concentration of these ions inside and outside of the cell, this resting membrane potential is maintained. Okay, this is resting membrane potential. It is resting membrane potential. When the heart is not contracting, at that time the potential is this. In the automatic fibers, in the non-automatic fibers and automatic fibers, you have to learn these values. Here it is minus 90, here it is minus 60. I hope you got it. So I'm talking about this cell. This is non-automatic fiber. Here, can you see this cell? The resting membrane potential of this cell is minus 90 millivolt. Can you see the square cell? Can you see the square cell? The resting membrane potential of this cell is minus 60 millivolt. So I'm talking about these cells. Now, out of these ions, usually potassium is more intracellular. Potassium is usually more intracellular, and sodium, calcium, and chloride are usually more extracellular. So intracellular potassium concentration is high, and extracellular sodium, calcium, and chloride concentration is high. Normally it occurs like this. Okay, so these are the basics you should know. Now let's start the action potential. I told you, action potential is different for automatic and non-automatic fibers. So let me tell you the action potential. Let's start the action potential. As I told you, it is different for non-automatic fibers and automatic fibers. Now you understand these terminologies. So I will discuss the action potential ka graph one by one. Let's take the graph of non-automatic fibers. Let's take the graph of action potential graph of non-automatic fibers first. Okay, non-automatic fibers. So I'm talking about these fibers, the contractile one, the one which cannot generate the impulse, the one who are just contracting the heart, conducting the signal and contracting it. That is atrial and ventricular fiber. I'm talking about that. So let's discuss the action potential of non-automatic fibers, that is these fibers, non-automatic fibers. So there are 5 phases in the action potential. Have a look on the graph. I will explain all 5 phases one by one. You can see phase 0, phase 1, phase 2, phase 3 and phase 4. So total 5 phases are there, including phase 0. So there is phase 0, then 1, 2, 3, 4. So total 5 phases are there in the action potential of non-automatic fiber. Please understand it. Okay, see this graph. Now one by one I will explain you the phases. Start with phase 0. We will start with phase 0. Let's start phase 0. So phase 0 is known as rapid depolarization. What will happen? Listen. So this is a cell. I have cut this cell from here. Can you see? I'm talking about non-automatic fiber, a cell of the ventricle. Imagine this is the ventricle. Can you see? This is the ventricle. I have cut one of the cell of the ventricle and this is the cell. Appreciate this cell. Now you can imagine, or you can imagine this cell. This cell. I have cut one of the cells from the ventricle from here. You can see it is a non-automatic cell. It is not a cell of SA node, AV node. No, it is non-automatic fiber. So I have cut one of the cell of non-automatic fiber and here is the cell. So as soon as it receives the signal, this cell receives the signal from the automatic fibers. Okay, it cannot generate the signal. I told you, no, this one cannot generate the signal. It will receive, it will conduct the signal. As soon as it will receive the signal via the pathway, it will receive the signal. The sodium channels will open. The sodium channels will open. That is phase 0. So as soon as it receives the stimulus, which is generated by the automatic fiber, not by them, the sodium channel open. When the sodium channel open, there is rapid influx of sodium. Appreciate the word rapid. Rapid influx of sodium. You can see rapid influx of sodium that will cause depolarization of this cell Okay, what was the resting membrane potential? Here the resting membrane potential was minus 90 before signal come. It was minus 90. Now because of opening of sodium channel and rapid sodium influx, it changes from minus 90 to plus 30. Plus 30. So it changes from minus 90 millivolt to plus 30 millivolt. Learn phase 0. In phase 0, the action potential changes from resting membrane potential, that is minus 90 to plus 30, because of opening of sodium channel and rapid influx, rapid influx of the sodium. Okay, because I will teach you antiarrhythmic drugs now. I will teach you class 1. Class 1 are sodium channel blockers. So first you understand where are the sodium channel, then you will understand sodium channel blockers, otherwise how you will understand. So please understand, these are the rapid influx of sodium, and that will depolarize the cell very fast and overshoot it to plus 30 millivolt. So phase 0 is done. Phase 0 is done. You can appreciate parallel graph. So I will show you this diagram. Okay, and I will show you parallel graph. By the way, all these diagrams are given nowhere. You search the entire world, you search the entire Google, you search entire books in the world. No, I have drawn all these diagrams for you myself. Okay, that's why it took so long, but I want to tell you from the scratch. I want to teach you physiology. So today I'm telling you from the complete session, half of the session will be physiology. Why I'm teaching you physiology? I'm not committed to teach you physiology. Okay, I'm committed to teach you pharmacology in this session. I can start directly from the classification of the drug. The session will last in 1 hour, just 1.5 hour. No, but I'm taking a long session so that you have a understanding. That's why it took long. I have created all these diagrams, and from the scratch I am taking. Okay, chalo, come back. So can you see this diagram now? You can see the sodium channels are opening and there is rapid influx, and the potential is changing from minus 90 to plus 30. So see, first you understand this diagram. The resting potential is minus 90. Appreciate the resting potential. Appreciate the resting potential, minus 90. The resting potential was minus 90. This is RMP. It is minus 90. As soon as the sodium channel opens in phase 0, this is phase 0, I'm talking about phase 0. As soon as the sodium channel opens, there is rapid influx of sodium. Appreciate, I have drawn it here also. So there is rapid shoot of the potential. From minus 90, it becomes plus 30. This is phase 0. Okay, this is phase 0. Phase 0. It is known as rapid depolarization. The name of this phase is rapid depolarization. It is known as rapid depolarization. Phase 0 is done. Coming on phase 1. After that, the sodium channel close. See, rather than reading it here, see. So sodium channel close and potassium channels are opening, not completely but partially. Mind my words, partially, slowly and partially. So sodium channels are closing, but potassium channels are opening briefly and partially. Briefly, partially. So small, not rapid, small amount of potassium goes out. So potassium efflux, but not much, small. Mind here I have drawn 3 arrows to show you the rapidity. Here I have drawn 1 arrow to just show you sluggishness. Okay, I have taken much care to draw all these diagrams. Please, people, appreciate it. Okay, so you can see there is efflux of potassium, but a little efflux of potassium because the channel is opening partially and slowly. So little bit potassium is going out. So the potential will drop. In phase 0, the potential was 30 millivolt. From 30 millivolt, it becomes 0. Initially, it was minus 90. From minus 90, it becomes plus 30. Plus 30 in phase 0. In phase 1, from plus 30, it becomes 0 millivolt. Okay, this is because of opening of sodium channel and sodium influx, rapid sodium influx. This is due to opening of potassium channel and slight potassium efflux. So the potential changes from plus 30 to 0. It is known as isoelectric potential, 0. So you can see the sodium channel closed, sodium channels are closed, and potassium channels open. Potassium channels open, but briefly. So small amount of potassium is going out. So slight drop in the membrane potential, and it is returning to isoelectric potential, that is 0 millivolt. I hope you got it. It is returning to 0 millivolt. You can appreciate the same over here. Start from the beginning. The resting membrane potential was minus 90. You can appreciate it was minus 90. In phase 0, due to opening of the sodium channel, appreciate sodium channel, rapid influx of sodium, and it reaches to plus 30. It reaches to plus 30. Now potassium, appreciate the potassium channel. They are opening but partially. So little bit of potassium is going out and it is dropping the potential to 0. See, it's 0. So this phase, a small phase, this is phase 1. This phase is phase 0. See at this line. And this phase is phase 1, in which it is returning from plus 30 to 0. So minus 90 to plus 30 is phase 0. And plus 30 to 0, it's phase 1. Phase 1, which is known as early repolarization. Phase 1 is done. Now coming on phase 2. Let's come on phase 2. Let's start phase 2. I hope you are getting it. It's difficult. but I will make a cakewalk for you. I work very hard on this chapter, people. Okay, I cannot compromise with the quality. Maybe it's my good property or bad property, I do not know. I take time, but I do not compromise with the quality of the content. Okay, sure. It will be very easy. Just focus here. So coming on phase 2. What will happen on phase 2? See these diagrams. Now, sodium channel is already closed. Okay, potassium is opened sluggishly, slowly. Calcium also open. Potassium is already open, it's not closed. Calcium also open. So from the potassium channel, potassium efflux was taking place. Okay, the same amount calcium influx it takes place and they balance each other. So here the potential is maintained at 0. It is maintained at 0. That's why it is known as play 2 phase. Play 2 phase. You got it? So here the slow calcium channels also open, and calcium influx and potassium outflux, efflux, they balance each other. The inward flow of the calcium is equal to the outward flow of the potassium. They balance each other. Since they balance each other, it is flat play 2. You can appreciate this is flat. It is 0 only. At 0 it is maintained for long. And here the actual contraction of the heart, the systole is taking place. In the cardiac cycle, the systole is taking place here. So here the potential is maintained at isoelectric level only. I hope you got this diagram. So sodium is already closed. Potassium was opened in phase 1. In phase 2, it's still open. It's still open. Potassium in phase 1 and phase 2, it's still open. But calcium also open. Since the calcium also open, they balance each other. And here, the potential is maintained at 0. Okay, you can see it here. I will draw all three. Appreciate it here. Everyone appreciate. So I'm drawing first phase 0. You appreciate it. So you can see in phase 0, initially it was minus 90. The resting membrane potential. Never forget. This one is resting membrane potential. When the sodium channel opens in phase 0, there is sudden shoot up from minus 90 to plus 30. This is phase 0. This phase is known as phase 0. Okay, that is rapid depolarization. After that, potassium channel opens slowly, okay, sluggishly, partially. Little bit potassium goes out. So from plus 30, it becomes 0. So this phase from here to here, this phase plus 30 to 0. This is phase 1. This is phase 1. Now, potassium is already opened. Potassium was opened here. Potassium is also opened here. It's already opened. But calcium also opened. So, potassium efflux and calcium influx, they balance each other. And it is still 0. So, this phase from here till here, this is phase 2. This is phase 1. This is phase 2. So, phase 1 is only this one. And phase 2 is complete this one. This is known as play 2 phase. Play 2 phase. It is due to potassium and calcium balance each other. So I hope you got it till now. Coming on phase 3. Okay, phase 3 is repolarization. Depolarization is done. Okay, this is rapid depolarization. This is early repolarization. This is play 2. Now we will do fast repolarization. Now calcium channels closed. Sodium was already closed. Okay, now calcium also closed. But potassium open completely. Not slowly, not partially, not sluggishly. They open completely. See the number of arrows I have drawn. So there is rapid potassium efflux. Potassium efflux was taking place in phase 2 also, phase 1 also, but it was slow. It was less. Here it is rapid. So mind the word rapid. Rapid. Okay. Calcium channel closes. Calcium channel closes. And potassium channel fully open. Fully open. And that's why the potassium is running out like anything. The potassium is running out. And the membrane potential again become minus 90. That is resting membrane potential. It reaches to the resting membrane potential. In all of them, I am talking about this cell. People, in this cell, all these changes are taking place. We are talking about non-automatic fiber. So first sodium channel open, then sodium closed, potassium open partially, then calcium also open, then calcium closed but potassium open completely. All the things are taking place in this cell. We are talking about this cell. These are the phases of this cell, the non-automatic fiber. That's why on every page I am giving you this diagram so that you have orientation. We are talking about this cell in which all these things are taking place. So this is phase 3. So in phase 3, again it becomes resting membrane potential, minus 90. In phase 3, again it reaches to minus 90. Till here I have already explained you. It was play 2 from here to here. This is play 2 phase 2. Okay, now you can see potassium channel fully open. So rapid potassium efflux, and that is dropping the potential again to minus 90. So it again reaches to minus 90. So this phase from here to here, this is phase 3. This is phase 3. It is due to completely opening potassium channel. Now finally phase 4. In phase 4, all the channels close. Sodium also close, potassium also close, calcium also close. Sodium was already closed. Calcium was already closed. Okay, here potassium was fully open, that is also closed. All three are closed, and sodium potassium pump will come in the role. It is not sodium, it is not potassium, it is sodium potassium pump. That is a separate pump apart from these channels. So sodium potassium pump will come in the role, and that will maintain the resting membrane potential to -90 till the next impulse comes, till it receives the next impulse. Okay, that is a refractory period. So that is phase 4. In phase 4, sodium potassium pump have a role. So you can see 3 sodiums are going out and 2 potassium are coming in. So all the channels close, all 3 channels, sodium, potassium, calcium, they all close, and sodium potassium pump comes in the role, and they maintain. It is maintaining. Three sodium goes out and 2 potassium comes in, and they are maintaining a stable resting membrane potential. Highlight the word stable. It's stable. It's -90. It's -90. Once the resting membrane potential is achieved, it do not decay. In contrast, I will teach you next the automatic fiber, in which the phase 4 is not like this. In phase 4, once the RMP is achieved, it will decay. It's not stable, it's unstable, and that's why they are the pacemaker. Rest of the phases are same, but phase 4 is different. Here in phase 4, the resting membrane potential is stable because of these, the sodium potassium pump. The sodium potassium pump are maintaining it for long. They are not decaying the resting membrane potential. See in the graph. Once it is achieved over here, it is maintained. See the maintenance. Maintenance is sodium potassium pump. Appreciate the sodium potassium pump. The sodium potassium pump is maintaining it. Okay, and it's still -90 till the next impulse comes, and the cycle repeats. So here the RMP, resting membrane potential, that is -90. Once achieved, do not decay unless and until the next impulse comes. And that's why these are non-automatic fiber. They cannot generate the impulse. I will tell you the next one, in which phase 4 the RMP will decay. So here they are ready for the next cycle. So this is phase 4. I hope I told you all the 4 phases. Can I summarize all the 4 phases? I'm talking about non-automatic fiber. That is atrial and ventricular fibers. I'm talking about them. I'm not talking about SA node, AV node. I'm not talking about automatic fiber. I'm talking about non-automatic fiber, the atrial and ventricular fiber. Okay. So there are 5 phases. Phase 0, 1, 2, 3, 4. In phase 0, quickly see. You can quickly revise. In phase 0, sodium channel opens, and there is rapid sodium influx. There is rapid sodium influx. Okay. Because of which the membrane potential changes from -90 to +30. Okay, you imagine the graph. I will show you graph in that. Okay, -90 to +30. In phase 1, this closes but potassium open. But it's partially open. So little bit potassium efflux. So it changes from +30 to 0. +30 to 0. Okay, because of this. Now, this is already open. This is already open, but calcium also open. So they balance each other. The potassium efflux and calcium influx, they balance each other. So 0 is maintained at 0. 0 to 0. So here it was -90 to +30 in phase 0. In phase 1, it's +30 to 0. Okay. And in phase 2, it's 0 to 0. It is play 2 phase. It is maintained there. Okay. In phase 3, potassium channels open completely. The calcium close. Here calcium was open now. It is closed now. And potassium will open completely. So rapid efflux of the potassium. Okay. And it is changing the potential from 0. Till now it was 0. Okay. It is changing from 0 to -90 again. -90 again. That is phase 3. That is repolarization. And once -90 is achieved, we have to maintain it till the next impulse. Maintenance is important, and that's achieved in phase 4. In phase 4, it is maintained at -90 millivolt till the next impulse is received, and it is done. None of these 3 channels, all these 3 channels closes. It is due to sodium potassium pump. So sodium potassium pump come in the role. So I hope you got it. I hope you got it. Here, see the summary. All 5 phases in front of you. Non-automatic fiber. Non-automatic fiber. People appreciate my efforts. Appreciate. I have done a real hard work to make it. Appreciate the effort. See the 5 phases. See phase 0, phase 1, phase 2, phase 3, phase 4. Appreciate the 5 phases of non-automatic fiber, that is atria and ventricular fibers. See how action potential is generated. So in phase 1, the action potential changes from -90 to +30 millivolt because of opening of sodium channel and rapid sodium influx. The summary of phase 0. In phase 1, the sodium closes, which was opened here, it closed here. Now the potassium opened, but partially, not completely. And the potential changes from +30 to 0. Here it was +30, it changes to 0. +30 to 0 because of opening of potassium channel. So see, it was -90 to +30, it's +30 to 0. Now coming on phase 3. In phase 3, this one was opened now. So this is still opened here. Potassium is still open, but calcium will also open. And the potassium influx and calcium influx, they balance each other. So here the 0 is maintained till long, 0 to 0. Here it is plus 30 to 0. Here it is 0 to 0. It's play to phase. It's maintained till long. Okay, now calcium which was opened here, it will close here. It will close here. And potassium which was partially opened here, it will open completely. So rapid efflux of potassium. Okay, and it will change the potential from 0 to minus 90. This is repolarization phase 3. And finally all three close. All three close. And sodium potassium pump come in the role, and it maintain the potential at minus 90 for longer period till the next impulse is received. So see the 5 phases. People, see the 5 phases and learn them very thoroughly, so that I can start the antiarrhythmic drugs and I can tell you the mechanism of action, which drug is acting on which phase and blocking what. Got it? So in phase 0, the potential is changing from minus 90 to plus 30 in phase 0. In phase 1, it is plus 30 to 0. In phase 2, it is 0. It is maintained at 0, play 2. In phase 3, from 0 to minus 90. And in phase 4, it is maintained at minus 90 because of sodium potassium pump. Now I will teach you automatic fiber, in which phase 4 is drastically different, in which they don't have sodium potassium pump. So minus 90, they don't have resting potential as minus 90. I told you the resting potential of automatic fiber is minus 60. So they are minus 60. Once achieved, it is not maintained. It got decayed, and that's why they are the pacemaker. I will come on it. So I hope you got this graph very well. In this graph also, I will mark the phases from where to where, just for confirmation. So phase 0, starting from minus 90 from here till plus 30 to here. This is phase 0. Appreciate 0. Here from 0. From plus 30 to 0, this is phase 1. This is phase 1, from plus 30 to 0. And maintenance at 0, this is phase 2. Appreciate phase 2, from here to here. Maintenance at 0, play 2 phase. From 0 to again minus 90, this is phase 3. This is phase 3. And maintenance of minus 90 is phase 4. And which channels are conducting it? It's also highlighted, already highlighted. All the homework is done for you. You have to just grasp it. So phase 0 is due to sodium channel. Phase 1 is due to partial opening of potassium channel. Phase 2 is due to partial potassium and calcium channel. Phase 3 is complete opening of potassium channel. And phase 4, most important, is due to sodium potassium pump. So this is a summary you have to learn. You have to learn the potential is changing from what to what, due to what channels, and you have to understand this graph. All the drugs I will explain you in this graph. This is the basal graph. You have to understand. Okay, so we are done with the action potential of non-automatic fiber. I taught you the 5 phases. Now coming on the next next version. So let's come on the action potential of automatic fiber. Can I start the action potential of the automatic fiber? I must start. So automatic fiber, I'm talking about them. I'm talking about SA node, AV node, okay, bundle of His, Purkinje fiber. I'm talking about the action potential of them. What's the difference between action potential here and here? Here action potential is not generated. They are just getting the impulse and contracting them. Okay, we understood, but they are generating the impulse. So how impulse is generated? How the action potential here and here is different? The main difference is the phase 4. So here I will start with phase 4. Okay, so here in automatic fiber, I will start with phase 4. So first I will tell you phase 4. After phase 4, I will start with 0, 1, 2, 3. So phase 0, 1 is absent here, 2 is absent here, 3. So here only 3 phases are there. 1 and 2 is absent. This is the graph. You can see this is the graph. I will show you the graph. This is the graph. Here we have only 3 phases. Phase 4, phase 0, phase 3. We don't have after 0, we don't have 1 or 2. We don't have after 0, directly phase 3 is there. I hope you got it. So instead of 5 phases, here we have only 3 phases, or you can say phase 2 is very brief or almost absent or very brief, but phase 1 is definitely absent. So that is automatic fiber. One by one I will explain you. So let's start with phase 4. Here I am starting with phase 4 because I have to do the pacemaker activity first. Pacemaker activity occurs in phase 4 because resting membrane potential will decay there. So let's start phase 4. Okay, what happens in phase 4 in non-automatic fiber? The resting membrane potential was already achieved in phase 3. In phase 4, it is just maintained because of sodium potassium pump, if you remember. Here we don't have sodium potassium pump. On these cells, the God has not given sodium potassium pump. I'm talking about these cells. Can you appreciate these cells? These are the automatic fibers. God has not given sodium potassium pump on these cells. I wish, thankfully the God has not given. That's why we can generate the impulse over these cells. Got it? Here the sodium potassium pumps are given. That's why they cannot generate. Once the action potential, resting membrane potential is achieved in phase 3, it is maintained Here, once the action potential, resting membrane potential is achieved in phase 3, it is not maintained. So here, instead of on these cells, automatic fiber, instead of sodium potassium pump, the God has given funny sodium channels. Funny sodium channels. So please understand, in phase 3, after complete repolarization, when the resting membrane potential is achieved, the funny sodium channels open. Can you see these funny sodium channels? They open and there is sodium influx. And not only this, the calcium channels, the T-type calcium channels also open and calcium influx also taking place. This both is taking place in phase 4. Remember the phase 4 there. Compare the phase 4. In phase 4 of non-automatic fiber, the sodium potassium pump was balancing the resting membrane potential at -90 till the next cycle achieved. Here it is not balancing. Here the influx of sodium and influx of calcium. Sodium influx because of funny sodium channel and calcium influx because of T type of calcium channel. So that is phase 4. So because of funny sodium channel, sodium influx, and because of calcium T type channel, calcium influx. Both influx taking place. That's why RMP will decay. The resting membrane potential is not maintained. It will decay. It will reach the threshold. It will reach the threshold and it will be able to generate the impulse, and that is known as automaticity. Automaticity is the capability of generating new impulse. So that is automaticity. I hope you got it. Because of the funny sodium channel and calcium, T-type calcium channel. So sodium influx and calcium influx. I'm talking about this cell, automatic cell, in phase 4. So you can see in the graph, here the resting membrane potential is -60, not -90. I told you in the beginning only. Here the resting membrane potential is -60 in contrast to non-automatic fiber where the resting membrane potential was -90. Here it is -60. Okay, now here you can see funny sodium channels open, appreciated, and T-type calcium channel opens, appreciated. So sodium influx, calcium influx, appreciate the sodium influx, appreciate the calcium influx. So you can see the membrane potential is decaying. It is not maintaining at -60 in contrast to non-automatic fiber where it was maintaining at -90 for long. Here it is not maintaining. It is rising and reaching to the threshold. The threshold is -40. So in phase 4, it is changing from -60 to -40. -40 is the threshold at which the action potential can be generated. So it is ready to generate the impulse. So this phase is known as phase 4. It is phase 4. So -60 to -40. This is phase 4 due to two channels, funny sodium channel and T-type calcium channel. So sodium influx, calcium influx. So membrane potential, resting membrane potential changes from -60 to -40. -40 is the threshold. So same story in the form of the flowchart I have written in front of you. So I hope you got it. In contrast there, appreciate the phase 4 there. Phase 4 here, once -90 is achieved, it is maintained. Appreciate, it is maintained because of sodium potassium pump. It is not decaying. It is not reaching to the threshold. Here the threshold is -70. It is not reaching. It is not generating the impulse. In contrast here, it is increasing and reaching the threshold. Here sodium potassium pump is not there. I hope you got it. Okay. I hope you got it. Okay. Now we have automatic fibers. There are many types of automatic fibers. We have SA node and we have all others, that is AV node, bundle of His, Purkinje fiber. Why SA node is the main pacemaker and all of them are latent pacemaker. So it depends on the slope. It depends on the slope of phase 4, how fast they can generate the next impulse. So the steepest slope, I must say the steepest slope is present in SA node. SA node. Okay, the graph is same for all of them, for SA node, for AV node, for bundle of His, for Purkinje fiber. But this slope is steepest in SA node. The phase 4 slope, it is steepest. That's why self-excitation is very fast. That's why impulse generation is very fast. That's why this is the main pacemaker, real pacemaker, SA node. And all other, by all other I mean AV node, bundle of His, Purkinje fiber. Here, the phase 4 depolarization is slow. I mean the slope is not that steep. The slope is relatively flat. Okay, so they are slow. So till they generate the next impulse, before that they receive it from the SA node. SA node is very fast. Okay, so they can also generate the impulse. They have the ability. So if SA node is non-functional, they will come in the role. But they generate the impulse at a slower speed. Before they generate it, they receive the impulse, which is propagated, which is generated by SA node. So these are known as latent pacemaker. I hope you got it. Okay, so phase 4 is done. After phase 4, we have phase 0. That is rapid depolarization. Okay, here L-type calcium channel will open once the threshold is achieved. What's the threshold? -40. You can see it here. -40. Once the -40 threshold is achieved, L-type calcium channels open. T type are opening in phase 4. Here L type calcium channel opens. So there is rapid influx, mind my words, rapid influx of calcium taking place. So you can say rapid influx of calcium taking place, and potential will rise from -40 to approx plus 30. -40 to plus 30, approx plus 20 plus 30. Okay, so that is the peak. Okay, calcium rush rapidly, and there is the upstroke up to plus 30. So initially it was -60 to -40 in phase 4. In phase 1, it's -40 to plus 30. This one is due to funny sodium and T-type calcium channel. And this one is due to L-type calcium channel. Please understand if you want to really understand the mechanism of action of the drugs. Now, phase 1 is absent. Phase 2 is very brief or absent. Coming directly on phase 3. Phase 3 is same as that of non-automatic fiber. There is no difference. What was happening in phase 3 in non-automatic fiber, you remember? Sodium channel close, calcium channel close. Potassium channel open fully. So here also potassium channel open fully. And there is rapid efflux of potassium. So same thing is happening. So calcium channel close. Sodium to यहाँ open हो ही नहीं रहता, sodium but not at all opening over here. Potassium fully open, potassium rushed out, and again it is reaching from plus 30 to -60. So this is phase 3, plus 60 to -60, and it is reaching to resting membrane potential. That is -60. That is phase 3. But it is decayable. I mean, it will decay. Once it is achieved, it is not stable. See, if it was a straight line, it is stable. But here the line is upstroke. It is reaching to the threshold, and that is automaticity. If it was stable, that is not automaticity. You see the graph of non-automatic fiber. Appreciate the graph. Got it? And the cycle repeats. SA node never rest. Okay, it starts before birth only in the fetal life, and till death it works. Okay, when the SA node stop working, the person dies. The heart stop pumping. Got it? SA node never rests, and that is the pacemaker that keep on generating the impulse, and that's why our heart keep on beating, whether we are sleeping, taking rest, but heart never rests. SA node never rests. Okay, so that is automaticity. I hope you got it. So what is the summary of automatic fiber? So I told you automatic fiber, the one which can generate the impulse, SA node, AV node, like this. Okay, so there are 3 phases: phase 4, phase 0, phase 1. Phase 4, phase 0, and phase 3. We don't have 1, 2. So this is phase 4. Okay, I'm talking about this cell. This is phase 4. Here funny sodium channel and calcium channel open. Sodium influx, calcium influx, T-type calcium channel open, and that is changing the potential from -60 to -40. -40 is the threshold. This is phase 4, and that is automaticity. Phase 4 is pacemaker activity. Now in phase 0, calcium channel, L-type calcium channel. Here it was T-type which was opening. It is slow, but L-type is fast. So you can see rapid influx of calcium taking place. So here it was -60 to -40. Here -40 to plus 30. -40 to plus 30. It will change. And phase 3 is there. Phase 1 and 2 is absent. Phase 3, potassium channel will open. So rapid efflux of potassium. So it will change from plus 30. Here we are at plus 30. From plus 30 to again resting membrane potential, that is -60, but that is again it will decay. The cycle repeats. So that is a summary. I hope you can see the 3 phases: phase 4, phase 0, and phase 3. Appreciate phase 4, funny sodium channel, calcium channel. Appreciate phase 1, L-type calcium channel. These are slow calcium channel, these are fast calcium channel. And in phase 3, appreciate potassium channel open fully. You have to learn all these, people. Got it? Appreciate the graph. Phase 4 start from -60 to -40. This is phase 4. Phase 4 start from -60 to -40. Okay, phase 0 from -40 to plus 30. This is phase 0. Okay, and phase 3 from plus 30 to again -60. This one, plus 60. So this is phase 4, phase 1, phase 3. Okay, phase 4, phase 0, 1 and 2 is absent, and this is phase 3, and this is again phase 4. It is continuing. Okay, and appreciate the ions channels in that. So we are done with the action potential here and action potential here. Yes or no? We are done or not? So let me tell you the comparative table. Everyone on the screen, focus. If you have not understood, see it again, but focus. Okay, you have to understand if you want to really understand the mechanism of action of drugs. If you just want to mug it up, it's okay. But if you want to understand, you have to understand all this. Okay, so non-automatic fiber, automatic fiber. Non-automatic fiber, automatic fiber. The non-automatic fiber are atrial and ventricular fibers. Yes or no? And the automatic fibers are SA node, AV node. Okay, these are the pacemaker. These are the pacemaker. They can generate the impulse. These are the pacemaker. These are not pacemaker. They conduct and contract. They conduct the impulse from here, and after that they contract. They do not generate. So this we already know. Here resting membrane potential is -90 and that's stable till the next impulse comes. Here resting membrane potential is -60 and that's unstable. It keep on decaying, and that's why this is the pacemaker. Till now you got it. Now compare phase 0, 1, 2, 3, 4 of both of them. Compare the phases. Compare the phases. Would you do it for me? Please help me out now. It's difficult for me also. So phase 0. Compare the graph of both of them. See the graph of non-automatic, see the graph of automatic. See the phase 0. Here the phase 0 is due to sodium channels. And here the phase 0 is due to funny sodium. Sorry. It is not due to funny sodium. The phase 0 is due to fast calcium here. By mistake I have marked the phase. So here phase 0 is due to fast calcium. See the phase 0, see the phase 0. Compare the phase 0. So that's what it is written. So phase 0, here it is due to sodium influx and here is due to calcium influx, L-type calcium. Rather than mugging it up, appreciate in the graph. You learn these two graphs. I have drawn these graphs for you. It is nowhere given in such a simplified form. I have read 7 different textbooks of pharmacology and searched for the simplest version I can combine and recreate for you. Okay, nowhere it is given in such a simplicity. Okay, everywhere it's a complex mechanism so that it goes a bouncer. But here with the help of flowcharts and these graphs, you know, the drugs will be very easy for you. The difficult portion is physiology, but the drugs are very easy. Once you understand the physiology, it will be a cakewalk. So compare the phase 0. Now come on, phase 1. Phase 1 and phase 2. So here you can see phase 1 is due to potassium and phase 2 is due to calcium potassium balance. Phase 1 is due to potassium efflux and phase 2 is due to calcium and potassium balance. Here phase 1 and phase 2 is absent. Phase 1, phase 2 is absent. Come on, phase 3. See the phase 3. Here phase 3 is same. Potassium efflux. Here also phase 3 is same. Potassium efflux. So phase 3 is same in both of them. Compare. So here also potassium efflux. Here also potassium efflux. Phase 4 is the real game changer. Appreciate phase 4. So here phase 4 means sodium potassium pump, which is maintaining the RMP. Maintaining the RMP. Appreciate the straight line. Here in phase 4, funny sodium and T-type calcium, they are decaying the RMP. Appreciate the decay. It's not a straight line, it's an upstroke. Okay, appreciate the straight line over here. Appreciate the straight line and appreciate the upstroke. Okay, so this straight line is maintenance of RMP and this upstroke is decaying of RMP in the phase 4. So here phase 4 is stable. Okay, here phase 4 is pacemaker. It's unstable. Here phase 4 is due to sodium potassium pump. You can see it's sodium potassium pump. Here phase 4 is due to funny sodium and T-type calcium. You can appreciate funny sodium and T-type calcium. People, I tried my best from the depth of my heart. I really tried best. I hope you got it. If you have any doubt, kindly text me. Okay. So you can see the 5 phases here and you can see the 3 phases here. Okay, this is for your understanding. This you don't have to learn. You have to learn these graphs. You have to learn these 2 graphs. You should be able to draw these graphs. Whatever ions I have shown you here, 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 here and here, they are already drawn in this graph. I have double drawn them so that you just learn this graph, everything is covered here. You just learn this graph, everything is covered here. If you understood this, you are ready to go. Okay, now before I start anti-arrhythmic drug, one more thing I would like to tell you, the properties of the cardiac cell. I will use these terminologies very frequently so that you have an understanding what I am talking about. What is automaticity? If I say automaticity, some drugs is increasing automaticity or decreasing automaticity. What do you mean by that? What is excitability? What is threshold potential? What is conduction velocity? And what is effective refractory period known as ERP? Effective refractory period ERP. I will use these terminologies in the drugs. So one by one we will deal it. So let's take the first one, automaticity. What is automaticity? Automaticity is the ability to undergo spontaneous depolarization. It is seen in automatic fibers. So I'm talking about automatic fibers. I'm not talking about non-automatic fibers. They have the ability to undergo spontaneous depolarization in phase 4. You can see their phase 4. So in their phase 4, they are undergoing spontaneous depolarization. Spontaneous. So this ability is known as automaticity. So phase 4 mein they are showing automaticity. Automaticity is pacemaker activity. So they have the ability to undergo spontaneous depolarization, that is their RMP is not stable. Okay, their RMP. So spontaneous depolarization is actually the pacemaker activity of the heart. It is seen in SA node, AV node. So that is automaticity. This property is known as automaticity. The spontaneous depolarization. The definition of automaticity is spontaneous depolarization. What is excitability? Excitability is seen in non-automatic fibers. So they don't have automaticity, but once they receive the impulse, they contract. So this is excitability. Ability to undergo depolarization, not automatically. Ability to undergo depolarization in response to a stimulus. When the stimulus come to them, then only they will depolarize. Here they were depolarizing here also depolarization is there. But here they were depolarizing spontaneously. Okay. And here also they are depolarizing. But they are depolarizing in response to stimulus. Got it? So tell me. So this is also ability to depolarize. This is also ability to depolarize. Both of them are ability to depolarize. Automaticity is ability to depolarize spontaneously. Khud se, spontaneously. And excitability is ability to depolarize in response to stimulus. So this is spontaneously, and this is in response to stimulus. In response to stimulus. Okay, this is spontaneous. I hope you are getting it. So ability to depolarize spontaneously is automaticity, and ability to depolarize in response to stimulus is excitability. So in short, I can say automatic fibers are having automaticity and non-automatic fibers have excitability. Okay, you should understand this language, the pharmacology language. Yes or no? The next thing I must tell you is threshold potential. I hope you get what is threshold potential. So I told you now, here the threshold resting potential is minus 90 and threshold is minus 70. You can see threshold is minus 70. So when from minus 90 it reaches to minus 70, there is rapid upstroke. And here the resting is minus 60 and threshold is minus 40. So from minus 60 to minus 40 when it is reaching, after that there is a rapid upstroke. So the minimum potential after which there is sudden rapid upstroke depolarization is there. So the minimum potential after which there is sudden rapid depolarization, that is known as threshold potential. I hope you can understand. Okay, conduction velocity. Conduction velocity is the upstroke of phase 0. Phase 0 is how fast it is. Phase 0, the fastness. See the upstroke, how fast it is. See the upstroke of phase 0, how fast it is. So that is conduction velocity. How fast the wave is traveling. The wave is formed here, but how fast the wave is traveling. The electric impulse which is generated, how fast it travels. That is known as conduction velocity. Okay, so conduction velocity depends mainly on the slope of phase 0. Slope of phase 0. Appreciate the slope of phase 0. Appreciate the slope of phase 0. That will decide the velocity or the speed of the electric signal. And last is effective refractory period. It is the minimum time between two waves. Appreciate this electric signal. Appreciate this electric signal. So the duration between the two. Okay, effective refractory period, during which the heart cell is not taking the next signal. It is effective. It is a minimum interval between two successive action potential. So this is one action potential, this is another action potential. So the minimum duration between them is effective refractory period, ERP. I will use all these terminologies, people. I hope you got the meaning of all these. Please, I guess they will not ask you, they will ask you in short question or very short question, but you should understand it for understanding the mechanism of action of the drugs. Now, last thing before I start, one more thing I would like to tell you. What is the effect of parasympathetic and sympathetic nervous system on heart? Okay, what is the effect of brain on heart? Okay, till now I taught you only heart. Heart is having its own rhythm. The heart can generate its own impulse. You can see automaticity is there in the heart and it is propagating and it is contracting. But does the brain have effect on the heart? Yes, brain also have effect on the heart. Does our brain control the heart? Yes, brain can also control the heart with the help of parasympathetic or sympathetic nervous system. In the brain, we have two types of nerve, parasympathetic and sympathetic. Parasympathetic is resting and sympathetic is emergency. I guess you know, you have watched my session on ENS. So what is the effect of parasympathetic and sympathetic system on SA node automaticity? The spontaneity, the SA node automaticity. So parasympathetic system causes bradycardia and sympathetic system causes tachycardia. We know whenever we are resting, our heart rate is normal. But whenever there is an emergency, there is a lion behind me, my heartbeat will be 150 more than that. So you can understand, here there is bradycardia, here there is tachycardia. What about the refractory period? Here the refractory period is prolonged, here the refractory period is shortened. The next wave comes very fast. Here the next wave comes slowly. Okay. What about conductivity and contractility? Here conductivity, contractility both decreases. Here conductivity, contractility both increases. I hope you understand these terms, people. So that is the effect of brain on heart. You got my point? Because some drugs I will teach you, the beta blockers, I will teach you beta blockers, the class 2 drugs, beta blockers. They will be acting via this system, na? The sympathetic, we will block the sympathetic pathway in beta blocker. So you must have an understanding how the brain is also controlling the heart. Okay, now let's start antiarrhythmic drug. How much time I took the physiology? This was necessary, people. Okay, so let's start the chapter now. Antiarrhythmic drug. Now I am actually starting the chapter. Antiarrhythmic drug. Still I will teach you first the types of arrhythmia, then I will come on the drugs actually. So what is antiarrhythmic drug? The drug which is used to prevent or treat the irregularities of the rhythm. What is arrhythmia? Arrhythmia is irregularity of the rhythm. So drug which is used to prevent it or drug which is used to treat it is antiarrhythmic drug. So you can't understand antiarrhythmic drug, people. You can't unless and until you understand what is arrhythmia. So before I start antiarrhythmic drug, now first you understand what is arrhythmia. Pathology. A little bit pathology. Till now we have seen physiology. Now we will see a little bit pathology. And then we will come finally on pharmacology. Yes, so that is the main thing in PBL, integration. Integration is important, people. Without integration, you can't understand your MBBS subjects. You have to integrate all 19 subjects. Got it? Chalo. So arrhythmia. Arrhythmia, first you tell me what is the introduction, what are the causes, what is the mechanism, what are the types. Then I will start antiarrhythmic drugs quickly in the form of my master charts. Right? So what is the arrhythmia? Arrhythmia is disturbance in cardiac rhythm. Now disturbance here or here? In both of them. Either here or in both of them. So there can be abnormal automaticity. Now you understand what is automaticity. So abnormal automaticity can be there or abnormal conduction is there. Abnormal conduction is there. So abnormal automaticity, that is seen in automatic fiber, or abnormal conduction, that is seen in non-automatic fiber. Both of them can lead to arrhythmia. So arrhythmia can be due to abnormal automaticity or abnormal conduction. Both of them can lead to arrhythmia. Arrhythmias are the most common cause of sudden death in human. Most common cause of sudden cardiac death in human is arrhythmias. I hope everyone got the introduction. What are the causes? Why there is disturbance in automaticity or conduction? Why there is disturbance? There can be 6 causes. Most common causes is ischemia. You know, myocardial infarction, MI. I taught you very well in pathology. Watch my sessions. So ischemia, or electrolyte or pH imbalance, or mechanical injury, or stretching due to heart failure. The ventricles are stretching, or it can be neurogenic, or it can be pharmacological. Do you know all antiarrhythmic drugs? Today I will teach you. They also can cause arrhythmia. Yes, the antiarrhythmic drugs can also cause arrhythmia. The treatment can be the etiology. Very funny, no? Yes, but this happens here. The antiarrhythmic drugs are also arrhythmogenic. The drugs which we are giving to treat arrhythmia can also cause arrhythmia. So that is the, mystery here, you can say. So these are the causes. I hope you got the causes, not the mechanism. We got the causes, we got the introduction, we got the causes, not the mechanism. There are 4 mechanisms of arrhythmia. There can be increased pacemaker activity. There can be ectopic pacemaker activity. Now please understand what is enhanced pacemaker activity, what is ectopic pacemaker activity. Please understand the difference between them. Where is pacemaker? Pacemaker is SA node. That is only enhanced. So that is enhanced pacemaker activity. Or apart from SA node, in atria or ventricle, that is non-automatic fiber become automatic. So that is ectopic pacemaker activity. Or there can be after depolarization. The 2 types of after depolarization: early after depolarization, delayed after depolarization, EAD or DAD. And there can be re-entry arrhythmia. So in short, we will see quickly and then we will come on the drugs. So one by one we will see them. The first one, enhanced pacemaker activity. The enhanced pacemaker activity in automatic fiber, that is SA node. See the SA node. Where is the SA node? See the phase 4. In the phase 4, if there is slope of phase 4 increases pathologically. See the slope. Okay. If it increases pathologically due to any reason, the slope of the phase 4 in automatic fibers only, which are already pacemaker. So pacemaker activity will be enhanced. The heart rate will be enhanced. Normal heart rate, what is the normal heart rate? 80 to 100. So it will be enhanced to 200, 300, 400, 500, it can happen. So enhanced automatic activity, enhanced pacemaker activity. This is known as enhanced due to increase in the slope of phase 4 of automatic fiber pathologically due to some disease. Maybe due to ischemia, maybe due to some other disease like that. Got it? What is ectopic pacemaker activity? This is seen in ordinary fibers. By ordinary, I mean non-automatic fiber. Suppose in non-automatic fiber there is ischemia. This is non-automatic fiber and I am talking about it. it have the ischemia. Because it has the ischemia, it will have mechanical damage. So inside which a new current will develop, which is known as injury current. Because of this injury, the new current will come inside it and it will start its own pacemaker activity. So it will start generating the impulse like this. So the non-automatic fiber behave like automatic fiber. It start generating the pacemaker activity inside that. Okay. And that is known as ectopic pacemaker activity. Ectopic. Normal pacemaker is this. But if this starts generating the impulse because of MI, because of injury current flows in that, and that can generate the impulse, and that is known as ectopic pacemaker activity. Okay, I know the terminologies are difficult, but with the help of flowcharts, some people it's very easy. Now coming on after depolarization, don't go in detail. Just learn these are the secondary depolarization accompanying a normal premature action potential. These are of two types: early after depolarization, delayed after depolarization. Early after depolarization, delayed after depolarization. I will tell you. So what is early after depolarization? This is early after depolarization. Can you see here? During phase 3. During phase 3. This is phase 3. Appreciate phase 3. During phase 3 depolarization, the membrane oscillate. The membrane potential is not coming to the RMP. It is not coming. It is oscillating here. And if the amplitude of oscillation is sufficient, neighboring tissue is activated and one extra impulse is generated. And this extra impulse is known as early after depolarization. Don't go in the detail. This is EAD. And same can be DAD. Once the resting membrane potential is achieved, after that, this action potential is there. This is delayed after potential. Okay, this is early after potential. This is delayed. Both here the phase 3 is not completed, and here phase 3 once completed and another wave is generated. So I hope you got it. Okay. Last is re-entry. What is re-entry? Due to abnormality of conduction, due to some abnormality, some obstruction in the conduction pathway, an impulse recirculate in the heart. An impulse, you can see it is recirculating in the heart. Okay. And repetitive activation without the need of the new impulse. Repetitive activation without needs of new impulse. This is known as reentrant arrhythmias. Reentrant arrhythmias. I will tell you treatment of this also. So we are not interested in the details of them that you will see in the physiology. But here I am interested in the pharmacology, in the treatment of them. Okay, so before I start, still I have to tell you something. Before I start, finally the antiarrhythmic drugs. The final thing I would like to tell you is the types of the arrhythmia. There are 7 types of arrhythmia. Because I will tell you in the uses of the drug, which drug is useful in which arrhythmia. So you must be understanding them. Na? If I say what is atrial flutter, what is atrial fibrillation, and what is supraventricular tachycardia, you understand the difference between 3. What is atrial flutter? What is atrial fibrillation? You understand the difference between the 2. Or between these 3. You understand what is ventricular tachycardia and ventricular fibrillation. You understand the difference between 2. So you should have a basic knowledge. The details you will see in medicine and the other subject. But here I will not give them much detail. But I will give you a basic knowledge so that you can understand in the uses when I will tell you which drug is useful in which arrhythmia. So you can understand why this drug is useful in this arrhythmia. Got it? So one by one we will take. First of all, extrasystole. These are the types of arrhythmia, people. First of all, we will take extrasystole. What is extrasystole? Extrasystole is premature ectopic beat. It is premature ectopic beat due to abnormal automaticity arising in atria or ventricle or AV node. Normal automaticity is in SA node. This is SA node. Can you see? This is SA node. So normal automaticity is seen in SA node. But if ectopic automaticity is seen in AV node, or in atria or in ventricle, so that is known as extrasystole. So here in each cardiac cycle, one systole is coming due to normal SA node and the other systole is coming due to the ectopic pacemaker activity. One is coming from the SA node, which is occurring in all of us, like the normal pacemaker. In every cardiac cycle, one systole is due to this and the extrasystole is due to the ectopic pacemaker activity, maybe due to AV node, maybe due to atria, maybe due to ventricle. The ectopic pacemaker activity is there. So main thing here is ectopic pacemaker activity, which is producing an extrasystole apart from the normal systole. I hope easy to understand. It is known as extrasystole, ES. I will tell you the treatment of it. Okay. The next is paroxysmal supraventricular tachycardia. Paroxysmal supraventricular tachycardia. Paroxysmal supraventricular tachycardia. So here atrial tachycardia is there. The problem is in the atria. What is supraventricular? Supraventricular. Okay, above the ventricle. Supraventricular. So the problem is in the atria. What is the normal heart rate? 80 to 100. Okay, atria and ventricle both are doing the heart rate of 80 to 100 in a normal heart. Okay, but here the heart rate become 150 to 200. Learn. In PSVT, paroxysmal supraventricular tachycardia, the heart rate is 150 to 200. Here the heart rate of atria ka heart rate is 150 to 200. Atria ka heart rate. Okay, and it's 1:1. Whatever is generated in the atria is transmitted to the ventricle. So ventricle ka heart rate is also 150 to 200. Both are contracting at the same rate, and it is 1:1. 1:1. So one wave, whatever generated in atria is transmitted to the ventricles. Okay, so it is 1:1 AV conduction. AV conduction is 1:1. Atrioventricular conduction, it is known as AV conduction, is 1:1. So both of them are conducting 150 to 200, 150 to 200. This is known as PSVT. PSVT, okay, paroxysmal supraventricular tachycardia. Coming on atrial flutter and followed by atrial fibrillation. Here the heart rate was 150 to 200. Here it becomes 200 to 350. 200 to 350. Okay, in the atria it's 200 to 350. In the ventricle it's not. In the ventricle it's still 150 to 200, because here the conduction block is there and it is 2:1 to 4:1. So here it is not 1:1. Two waves are there, one is here, two is here, one is here. So ventricle is contracting at half of the speed as compared to atria. That is atrial flutter. Because AV node cannot transmit the impulse faster than 200. Here the impulse faster than 200. So it cannot transmit. Maximum impulse transmitted to the ventricle is 200. So ventricle is conducting at 200 only. But atria is conducting from 200 to 350. And it is 2:1 block. 2:1. The AV conduction rate is 2:1. So two waves in the atria, two signal in the atria and one in the ventricle. One of them is transmitted to the ventricle. So that is atrial flutter. Now coming on atrial fibrillation. In PSVT the rate was 150 to 200. In flutter it is 200 to 350. Here it's 350 to 500. It's a continuation. See, here it was 150 to 200. Here it is 200 to 350. And here it is 350 to 550. 350 to 550. Atria is contracting at 350 to 550. Okay. And ventricle is contracting at just 100 or 150. Ventricle is contracting at 100 or 150. So again, there is 2:1 or 4:1 AV conduction ratio is there. But the point is that here atria fibers are contracting asynchronously. It is contracting at 350 to 550. I agree. वो तो ठीक है. That's okay. But here they are contracting asynchronously. That is the highlight. They are contracting asynchronously because of electrophysiological inhomogeneity in the atrial fibers. That is fibrillation. In fibrillation, the atria fibers are contracting inhomogeneously. Okay, they are contracting asynchronously. The rate is also high, but they are contracting asynchronously. That is the main thing. Now coming on ventricular tachycardia and ventricular fibrillation. Ventricular tachycardia, first ventricular tachycardia, VT, run of 4 or more successive ventricular extrasystole. So if we take a ventricle and minimum 4 or more than 4 ventricular extrasystole. Normally one atria systole, one ventricular systole, but ventricular systole become 1, 2, 3, 4 extrasystole and then the next atrial systole. It is ventricular tachycardia. In ventricular fibrillation, there is irregular, rapid and fractioned activity of the ventricles. Okay, and it's very fatal. If not treated within 5 minutes, the person dies. It is the most common cause of sudden cardiac death. Okay, and last is AV block. I guess you can understand what is AV block. Due to the depression of impulse conduction, the conduction cannot take place from the atria to the ventricle. That is AV block. So in short, I taught you the various types of arrhythmia. The details you will see in medicine, each of them. Okay, here I am interested in the pharmacology. So let's start pharmacology. People, now I'm starting the chapter. If I wish, I can start from this slide. Okay, actually in your books, whatever standard textbook you are following, whatever, open your textbook, it is started from this page. Okay, but I taught you the complete physiology. I taught you the complete pharmacology. I taught you a portion of medicine also. And that's why it took so long. I have prepared this session, very passionately because I want to give you the complete knowledge. Okay, so coming on the classification of the drugs. Here you can see we are dividing the anti-arrhythmia drugs into 4 categories. Okay, class 1, class 2, class 3 and class 4. First you learn that. We are dividing the anti-arrhythmia drugs into 4 categories, class 1, class 2, class 3, class 4. Class 1 is further divided into A, B, C. So class 1A, class 1B, class 1C. Okay, so total 6 categories of the drug. I will teach you all of them in the form of the master chart. You know my master chart, my famous master chart. So I will teach you all the categories, drugs one by one I will read. I am not reading it here. One by one categories I will take and I will read the examples, drugs inside each, and I will teach you all these drugs one by one. So this is anti-arrhythmic drugs. Have a look. Give me a minute. I would like to drink water and then we will continue the anti-arrhythmic drug. Chalo, let's continue. So you can see the antiarrhythmic drug. As I told you, we divide them into 4 categories: class 1, class 2, class 3, class 4. One is further divided into 3 categories: 1A, 1B, 1C. Let me tell you in short. I will tell you the detail of all of them. Class 1 are sodium channel blockers. Sodium channel blockers, and they act on non-automatic fibers. You remember non-automatic fiber? Non-automatic fiber का phase 0. Remember the sodium channels are non-automatic fiber of phase 0. I will show you the graph. They block those. Okay, they are of 3 types. All of them are sodium channel blocker. 1A also block, 1B also block, 1C also block. But they block the sodium channels moderately. They block the sodium channels weakly, and they block the sodium channel more strongly. Okay, so these are moderate blocker, these are weak blocker, these are strong blocker. Got it? So this is how you have to learn with the simplicity. These are sodium channel blockers. I will show you the graphs of each of them, the mechanism of action of each of them with the help of videos, animations, everything. Coming on phase 2, class 2 drugs. Class 2 drugs, these are your class 2 drugs. These are the beta blockers. Class 2 drugs will be beta blockers. Okay, they are beta blocker. Class 3 will be potassium channel blocker. These are potassium channel blocker. Okay, these are beta blocker. They act on automatic fibers. They act only on automatic fibers, not on non-automatic fibers. They act on both automatic as well as automatic, because phase 3 is in both. No, they are potassium channel blockers. They block the phase 3. You remember phase 3 of both automatic or non-automatic is same because of complete opening of the potassium channel and rapid potassium efflux. So they block that. They block that. Okay, and class 4 are calcium channel blocker. Actually, L-type calcium channel blocker. L-type calcium channel blocker, which are present only in automatic. Which are present in automatic fibers. You remember phase 0 of automatic fiber. So they block that. Okay, so I hope in short I taught you, and I will give you the detail with the help of graphs and videos and images. It will be very simple for you. So let's start it. These are my master chart. By the way, I am preparing, I am on the end of master charts of pharmacology also. I have already launched my master charts of the microbiology. Most of you may be aware. If you are not aware, I have completely launched my calendar of the microbiology, which is of 64 pages, in which the complete microbiology is taught in comparative columns, in which I taught 158 organisms, that is bacteria, virus, fungus and parasite, in comparative columns under a fixed set of heading, and that I call microbiology master chart. And I guarantee, I challenge that will replace the standard microbiology textbooks. You don't purchase textbooks, you just take these master chart and hang it on your wall. It's the calendar. You just hang it on your wall. Once you hang it on your wall, looking at the pages, you just keep on flipping the pages one by one, and all the organisms will fit in your mind. You even don't realize when they get fit. Okay, the same with the pharmacology. In pharmacology, all the chapters, 150 drugs of all systems, of all 8 human body systems, the more than 150 drugs are compared under a fixed set of heading. You know my fixed set of heading: introduction, mechanism of action, ECG changes, pharmacology, pharmacokinetics, uses and adverse effects. In the introduction, classification is also given. So I have compared them in the form of a calendar. So our pharmacology calendar is about to release. It is just for your information. So let's start it. So you can see this is the master chart over here, in which we will compare drug 1A, 1B, 1C under a fixed set of heading, drug 2, drug 3, drug 4. So in just 2 pages, page number 1, page number 2, in just 2 pages, that is 2 master charts, I will pack this chapter. I will teach you all these drugs in just 2 pages. So what you are waiting for? Take out your notebooks, take out your pen, make these columns with me, fill these columns with me, and you will realize how easy it is. Okay, so let's start it. Can we start? Let's start the antiarrhythmic drugs. So let's start with the class 1. Okay, in which I will teach you 1A, 1B, 1C, all of them one by one. Let's start with class 1. Class 1 act on non-automatic fiber. Which fiber? This fiber, non-automatic. You realize what is non-automatic till now. Okay, these are the one, the atrial fiber and ventricular fiber. They don't generate the impulse, so they act on that. And these are sodium channel blockers. You know, have you watched my session on local anesthesia? So they have local anesthesia-like action. They stabilize the membrane. Okay, the one which block the sodium channel, they stabilize the membrane. I taught you this in the local anesthesia. Watch that. So they have local anesthesia-like action, and they are of 3 types: 1A, 1B, 1B, 1C. I already taught you. They all are sodium channel blocker. They all are. This also block sodium channel. This also block. This also block. But this block moderately. This block weakly. This block strongly. You can see moderate blocker, weak blocker, strong blocker. They all are sodium channel blocker. They all are sodium channel blocker. But 1A is moderate, 1B is weak, 1C is strong. Say again, 1A is moderate, 1B is weak, and 1C is strong. They all are sodium channel blocker. They all are sodium channel blocker. First thing. Okay. Now I will show you. So can you see where is the sodium channel? See in the graph. See the mechanism of action of all three once at all. So can you see the sodium channel in the phase 0 of the non-automatic fiber graph? So see, this is non-automatic fiber. See the graph of the non-automatic fiber. Realize the five phases. Phase 0, 1, 2, 3, 4. Where is sodium channel? Sodium channels are in phase 0. Phase 0. Can you appreciate phase 0? Can you appreciate rapid depolarization? So they will decrease the rapid depolarization wala phase because they are blocking the sodium channel. Okay, 1A are blocking it moderately, 1B are blocking it weakly, and 1C is blocking it strongly. But they all are blocking the sodium channel in the phase 0 of the non-automatic fiber. You have to draw this graph in your exam, and you have to block it here. See the cross. Appreciate the cross. These are the sodium channels. They are blocked by 1A, by 1 class 1, 1A, 1B, 1C all. Now one by one I will discuss all three. Can I start 1A? In the one, first I will teach you 1A, then I will teach you 1B, then 1C. So can I start 1A? Quickly, let me start 1A. So as I told you, these are the moderate blocker. They are sodium channel blocker only, but moderate blocker. They block the sodium channel in open state. You know, sodium channels have three states: open state, inactivated state, and closed state. Okay, first it is closed state, then it is open, and then it is inactivated. I taught you all these in the local anesthesia. Watch that session. They block moderately and they block it in open state. What are the drugs in this category? We have three drugs. What are the three drugs? Quinidine, procainamide, and diazopyramide. So I will teach you two of them. I will teach you quinidine in detail and procainamide in detail. This I will not teach you in detail, not important.